Hi, I'm Dr. Dorr.
I'm Jenny Palmer.
Hi, Jenny. Very nice meeting you. Why are you here today?
My gynecologist recommended I should see you. She thinks I might have osteoporosis. I've had my DXA test, and I had some questions and concerns.
Okay, and this is the right place to be, so it's good. And she sent you a copy of your bone density test so we can go over those results after I ask you a few questions.
Right.
Have you ever broken anything?
I tripped and fell when I was 55, 10 years ago, and broke my wrist. But isn't it normal to break a bone when you fall?
Not probably at 55.
The doctor said that, the doctor at the hospital said that my bones were very strong when he put the plate in to repair it.
Normally, if they have to put a plate in to repair it, that means it's a significant fracture. So that's going to help me in making my recommendations to you about the bone density study. What about your parents? Did they lose height as they got older?
They did, actually, yes. Both my mother and my father. But I thought it was part of the natural aging process.
And that's what most people think, so you're, not unusual in that regard. But typically, as we age, if we lose height, it can be from having what we call compression fractures, where the spine bones actually compress just from the weight of carrying the upper body. So your parents, they both might have had osteoporosis that caused that. We, of course, don't know at this time, and about 70% of the time there's no pain associated with that loss of height, so they would not know. 30% of the time a patient will cough or sneeze or bend over and have the sudden onset of pain, and then that's a painful vertebral fracture. But most of the time they're not like that, so they certainly could have had osteoporosis. But did they break a hip?
Not that I'm aware of, no.
That's really important because it's really the hip fracture that is most important in judging what your risk of fracture is. So that's important. And you would have known because those are treated with surgery. So you would have known if they had that done. Now what about calcium and vitamin D? Do you take any supplements?
Well, I'm not very good at taking my calcium supplements. I tend to forget.
You're not alone. That's certainly very true. What about your diet? Do you get dairy products, leafy green vegetables? What do you get in your diet?
Well, I'm not a big milk drinker.
Okay.
And I sort of worried about cholesterol. And skim milk, well, it doesn't taste very nice to me.
No.
But I do like yogurt and almonds and spinach.
Good.
Are they good?
Those are very good. Other things that you could think about is orange juice has calcium added to it. Even eggs have calcium. Bony fish, if you don't choke on the bones, has calcium. So that the current recommendation is to try to get as much calcium in your diet as you can. So you're probably getting about 700 milligrams. So you really probably only have to take another 300 or 400. And those can be in liquid form, chewable form, pills that you take. It's really what's most convenient for you. I have most of my patients, if they need to take a calcium supplement, just put it in their purse. And so if they're out at lunch or if they forget, to take it at some time, they can take it again, sometime during the day. It's not like if you don't take it at breakfast, then you can't take it the rest of the day. Just any time to try to get someplace between 1,000 and 1,200 milligrams in your diet. What about exercise?
Well, I try to go to the gym several times a week, but I've been really busy recently, so I've been a bit irregular.
What about just your daily routine? Do you walk much?
Yes.
Okay.
Yes.
Yard work?
Yes. Gardening? Yes.
Good. Well, recent studies suggested that you don't have to huff and puff or sweat when you exercise in order to help your bones. So if you just wanted to think about just walking out the front door for 20 minutes or maybe just parking further away if you run to the store or do some errands, that's going to get you some of that weight-bearing exercise that's important. What about, are you doing some gardening or any housework?
Yes, lots of that.
Okay, so you have to be careful there because if you have low bone density or osteoporosis, if you do a sudden jerk, that could actually cause one of those broken bones in your spine.
Ooh.
So when we're done, I'm going to give you a handout that talks about how to bend and stoop and lift so you're less likely to have an injury to your spine. So we'll talk more about that. What about hormones? Did you take hormones after menopause?
I did actually. I took them for a few months, and my friends said they were dangerous, so I stopped taking them. Actually, I felt better when I took them. I didn't wake in the night with hot flashes. I just generally felt better.
And there's no question that hormones, improve bone density and actually prevent fractures. But because of the side effects associated with the hormones,
Yes.
they're not recommended now to take long term for osteoporosis. But any medicine has side effects, and so we're always looking at what, in your case, what the risk of a fracture is compared to the risk of a side effect from the medicine. Well, speaking of that, what about prednisone? Have you ever taken a cortisone, Medrol, steroids?
No. No.
That's good,
No.
because those are commonly taken for like rashes or asthma or breathing problems, and those by themselves can cause osteoporosis. So that's very good that you haven't taken those. What about smoking?
No, never.
Very
No.
good. Smoking is very bad and increases the risk of fracture, so that's good that you haven't done that. It really sounds to me like that you need another 300 or 400 milligrams of calcium, that you need to just try to make certain that you're getting that weight-bearing exercise, but not, 4 times a week, 20 or 30 minutes, that's really all you need to do. And you don't have to change your gym clothes, you don't have to go to the gym. It's just a matter of walking out and doing that weight-bearing exercise, which walking is. And it improves the strength of your muscles, so you're less likely to fall. And fall prevention is really important. So,
Yes.
and it sounds like you really have a lot of good, healthy habits. So, what about taking a look at your bone density study? So let me just take a look here in your chart. So what we see is when we're looking at a bone density study, what the T-score does is that's a measure of how your bone density compares to a 30-year-old. And you might say, I don't care about a 30-year-old, I care about a 65-year-old. But when we look at bone densities, that 30-year-old is when women probably have their peak bone density. So we would really like women to have their bone density be as close to that peak bone density as possible. And for every 10% decrease, you go down what we call a T-score, or standard deviation. So your T-score for your spine, osteoporosis is minus 2.5, you're minus 1.9. So not osteoporosis, but lower than we would like, again, for someone of any age, but certainly your age. And if we look at your hip bone density, that's actually minus 2.1. And so again, not osteoporosis, but when we look at your wrist fracture and your low bone density, you would have what we call a clinical diagnosis of osteoporosis. So some people say, well, I'm not minus 2.5, so I don't have osteoporosis. But that's why I asked you about that fracture. That's so important. So if we have someone like you whose bone density is not in the osteoporosis range, what we do is we use something called a FRAX tool. And this is something that we look on the internet and we put in all the different risk factors that I've talked to you about. We put in if your parents have had a hip fracture, if you smoke cigarettes, if you've ever taken steroids, and then we put your bone density measurement in there. And then we look at what your 10-year risk of having a major osteoporotic fracture or a hip fracture is. And it's recommended that your 10-year risk of hip fracture is more than 3%. Or if your risk of a major osteoporotic fracture, so that looks at your spine, your wrist, your shoulder, etc., if that's more than 20%, then the benefit of you taking a medicine is greater than the risk of a side effect from taking the medicine. So what I did before you got here today, so I would have this available, is I put your measurements into this FRAX tool. And what I found was that your 10-year risk of having that major osteoporotic fracture was actually 22%, so more than the 20%. And your hip fracture risk was 2.6%, so below that 3%. But based on this, it's really recommended that you take a prescription medicine because your risk of fracture is higher than it should be. So what I'd like to do, if we can, is really talk to you about some medicine. But I know some patients think, well, gosh, all I really need to do is exercise.
Yes, that's what I was going to say.
How did I know?
and have a better diet and exercise more. But I still You still think I need to take medication?
Right, and that's because I asked you all those questions beforehand. So I know that, you're missing 300 or 400 milligrams of calcium is all. I know that, you're active, and so that's, we just need to have you be a little bit more active. But the data suggests that in somebody whose bone density is low like yours, and especially with already having that wrist fracture, that calcium, vitamin D, exercise is really not enough, and you need to think about taking a prescription medicine.
So what would you recommend?
Well, I don't normally recommend a medicine, but I can talk to you about what the different options are, and then we can talk about the benefit versus the possible side effects and what you think would fit more likely with your lifestyle.
Right.
So one medicine that we use is something called raloxifene or Avista. This is a medicine that reduces the chance of having a spine fracture, and that was what you were more likely to have. It's a medicine you take every day. And the data has shown, as I said, it reduces spine fractures, doesn't reduce hip or other types of non-spine fractures. Something you take every day. Doesn't bother the stomach. Rarely, in some people, it can cause risk of having a blood clot in your leg. So if you travel, that might not be the medicine for you. Also, I wouldn't think at your age, but in a immediately postmenopausal woman, it can cause more hot flashes. So that's something that if you were prone to those before, that you might want to think about. But that's one choice, because what I like about it also reduces the incidence of invasive breast cancer. So if a woman is very concerned about invasive breast cancer, I think, well, it reduces spine fractures, it reduces the chance of having invasive breast cancer, so that's a possibility. The medicines that most women end up taking are what we call the bisphosphonates, and you're probably aware of those. There's a alendronate, which is Fosamax, there's ibandronate, that's Boniva, and there's risedronate, that's either Actonel or Atelvia. And typically these are taken half hour or an hour before breakfast with a full glass of water on an empty stomach. There's something also called zoledronic acid that's given once a year in your vein. So that's another possibility in this bisphosphonate category. Now, a lot of patients have heard about things and say, well, I don't want to take that because that can cause that jaw problem or those unusual fractures that it can cause that.
Yes.
But if those don't happen very, very often, and some people say, well, the side effects always happen to me. But if we're looking at the chance of this happening, if we're looking at that jaw problem, which is where you see part of the jawbone actually exposed, it happens someplace between 1 in 100,000 and 1 in 150,000 people. So that's not very many when we look at your risk of having a hip fracture in 10 years of 2.6%, or your chance of having another type of fracture of being 22%. So higher chance of having a fracture than there is a side effect. If we look at those unusual type of femoral fractures, we're looking at probably about 30 in 100,000 after you've taken the medicine for about 5 years. So that's, a long period of time. So again, something to consider, but if you have certain symptoms, we can try to talk about that and reduce the risk of that happening. Again, low incidence, low probability of that happening, but more likely for you to have a fracture based on those percentages that I gave you. Then there's something called denosumab or Prolia. This is a relatively new medicine, came out about 3 years ago, and that's a shot that you get in the doctor's office every 6 months, just a subcutaneous, just an injection under the skin in your arm. And that type of medicine, like the bisphosphonates, has been shown to reduce spine fractures and other types of fractures as well. And that also has been associated with that uncommon jaw problem and these atypical fractures. And again, it's so new we don't actually know the percentages there, but we think it's similar to that happens with the bisphosphonates. Right. And then there's another medicine. I know it's overwhelming, all the choices.
Yes.
It's nice to have all these different options. The next one is something you probably don't need because it's for patients who are at high risk of fracture. And that's a daily shot that you give yourself for 2 years, just with a little like an insulin-like device that you give yourself the shot. But I don't think that your osteoporosis is bad enough where we really need to consider that at this point.
Hope not.
So I think it'd be the daily pill, the raloxifene, or the weekly or monthly bisphosphonate, or the denosumab Prolia injections that you get every 6 months.
It's quite a big decision, isn't it?
It really is.
I don't really want to risk getting hot flashes again, and I don't feel entirely comfortable about a shot that's going to stay in my body for 6 months. I think I'd probably go towards the pill that I take by mouth. Have you got any material, any brochures that I could take away and read and think about over the next week or so? It's so that I make kind of the best decision for me.
It is a little overwhelming, all the things we've talked
Yes.
about. And of course, I have something that I can give you about all of these different products. Also going to give you just a general reading material about osteoporosis and about the FRAX tool, so you can really understand the reason that I based this decision for you to take a prescription medicine. I'm also going to give you a lab slip so we can check your calcium level. It doesn't tell us if you're getting enough calcium in your diet, but it makes certain that your calcium level isn't too high or too low, because then we would need to do some further testing.
Right.
Look at your vitamin D level to make certain that that is normal, because for these medicines, all the ones we talked about, to work the best, you need to have a normal vitamin D level. And then if you choose to take, though, the bisphosphonates, the one that you take once a week or once a month, half hour or an hour before breakfast, you have to have normal kidney function for that. So we'll check your kidney function. This is all on a simple blood test. And so we can use that to be helpful to me, again, what to advise you.
Right.
So what I'll do is I'll give you the reading information about the drugs and about osteoporosis in general. I'll give you the lab slip, and then if you could just contact me in a week or so when you've made the decision, then I'll have the results of the lab test back. We can talk about what your decision was, and then I'll want to hear from you again in a year, just so I can see how you're doing, make certain, if you've had any problems with the medicine. And please contact me in between if you have a problem. But definitely we need to check bases in a year, because then I need to check those blood tests again in a year. And then we'll get the bone density again in 2 years to see how things are going with whatever you decide to take.
Right. Thank you very much.
Pleasure
Thank
meeting you. Thank you so much. And I'll send a copy of what we talked about today and my recommendations to your gynecologist. And then after I get your blood test back and you decide what to do, I'll send that evaluation to her as well.
Thank you. Thank you,
I'll talk
Dr.
to you in a
Doe.
couple weeks, and then we'll see you back in 2 years.